It is my great privilege to introduce today's Grand Round speaker, Dr. Alexander H. Krist. Dr. Krist is Professor of Family Medicine and Population Health at Virginia Commonwealth University, where he also directs the Virginia Ambulatory Care Outcomes Research Network, one of the most robust practice-based research networks in the nation, engaging more than 500 primary care practices across 9 health systems. He also serves as Director of Community Engaged Research at VCU's Center for Clinical and Translational Research. Many of you will know Dr. Krist's scholarship and leadership on a national level. He is a member of National Academy of Sciences, Engineering, and Medicine, and he served as Vice Chair and then Chair of the U.S. Preventive Services Task Force, guiding its efforts to address systemic racism, integrate social determinants of health, and broaden inclusivity in preventive care recommendations. His research portfolio spans health equity, integration of primary care and public health, use of health information technology to engage patients, and strategies to strengthen implementation of evidence-based practice in real-world clinical setting. Dr. Krist has been continuously funded by NIH, AHRQ, and PCORI grant mechanisms and other agencies for more than 2 decades, leading studies that have shaped how we think about personal health records, community clinical linkages, and enhanced care planning for patients with complex needs. His work has appeared in high-impact journals such as JAMA and Health Affairs, and has informed both national policy and clinical practice. Beyond his scholarly impact, Dr. Krist is an exceptional mentor and educator, having trained hundreds of medical students, residents, and junior faculty who now carry forward his vision of advancing primary care research to improve community health. His recognitions include Ronald Davis Special Recognition Award from American College of Preventive Medicine, the Mid-Career Research Award from North American Primary Care Research Group, and most recently, Sheldon Retchin Endowed Chair at VCU. Please join me in welcoming Dr. Alex Krist, whose talk today will no doubt challenge us to think deeply about how we bridge clinical care, public health, and community engagement to achieve health equity. Dr. Krist.
That was a very kind introduction. I appreciate that. So I'm not very good standing behind things, so I was going to stand more in front, and there's screens here so I can see everything really well. And I'd like to kind of talk a little bit more informally. So if as I'm going through anything, you have any questions or want me to go into more detail on any of the stuff I talk about, just raise your hand and interrupt me, and we can make it a little bit more of a discussion as well. I was going to focus on the public health impact of practice-based research networks. So as you were hearing, I've been involved with our Virginia Practice-Based Research Network, ACORN, the Virginia Ambulatory Care Outcomes Research Network. Really since 2002, it was created in 1996 by Steve Wolf. And it really is a statewide resource, and a number of practices and clinicians and groups from here have been in our studies and done work with us in the past, and we very much want to keep that going. So I was going to talk about 3 things. So I wanted to talk about the concept of practice-based research networks and like, why do we need them? What are they and how are they important? I wanted to show you some of our different ACORN studies and try and show you how, you know, doing things in real-world primary care can have a very large public health population level impact on outcomes, and talk a little bit about some of the things that we're doing and that involve your area here. So the Agency for Healthcare Research and Quality is the funding agency that created PBRNs, and they have the website about PBRNs and the definition, and they say primary care practice-based research networks are groups of primary care clinicians and practices working together to answer community-based healthcare questions and translate research findings into practice. PBRNs engage clinicians in quality improvement activities, and evidence-based culture in primary care practice improves the health of all Americans. So in our network, we've always struggled with, well, what's our mission? What do we do? And we most commonly say, well, we do research that matters to primary care. And my favorite study is when we can do something where we can help patients and communities, we can learn something new, and we can also help the practices and the clinicians to make things easier and better than what they were doing before. So those are kind of the goals that we have. And PBRNs have this long history. If you go in and you do some lit searches, you'll find all kinds of articles from Larry Green, Jim Mold, John Hickner, Jack Westfall, other kind of leaders in primary care and practice-based research networks. And the concept's also been extended a little beyond primary care. So I've heard of dental PBRNs and even a mental health PBRN, but it's really trying to do research in the real world where we need it done. So this is ACORN. Some of the very first studies that actually we did that really engaged practices a lot were right here in this area. And I remember driving by the microtel that I stayed in because we had no grant money as I came to visit all the practices here. And as mentioned, we have 526 practices that are in ACORN. And we count any practices in ACORN if they've ever done anything with us. So a number of you are in ACORN and you don't know it, but we say you're in ACORN and hope that you'll continue to do things with us. The dots up there are all the ACORN practices. So you can see they're all throughout the state. They're in every health system. And we've always thought of ourselves as non-denominational. We just want to help primary care and we want to help the communities that they're serving. That's the goal. So here's the idea behind PBRNs and why we need it. This is a paper called The Ecology of Medical Care. And if you look in any one year in 1,000 people in the community, about 800 people will get symptoms of some type. I suspect it's higher than that, but this is what they put here. About 327 will seek medical care. 217 will go to a physician's office. And you go all the way down to that very bottom square. That's the less than 1% of people that are hospitalized at your academic medical center. And if you think of research classically, most research occurs in that 0.1% of the population. And that's not generalizable. It doesn't reflect our communities. It doesn't reflect the people we serve. So the idea with a PBRN is, well, you can move this further out. So you can get to those 327 people seeking care. And actually you can get further than that because a lot of people might have sought care a year before, a year before, a year before that, but they're part of that medical home in the practice and they're in the community as well. Another reason we need PBRNs, these are quality measures. This was from a study in 2003 by Beth McGlynn. It was done prior to that in the 90s and it was done in 2010 and 2018. They all show the same results. And the result is that if you look at evidence-based recommended care, whether you're talking about acute care or preventive care or chronic care, Americans only get half of the care that they need. So we're really bad at making sure that people get what they need. So a big part of what practice-based research networks do is to try and implement evidence-based recommendations and make it easy to get the right care to the right person at the right time, which is not hard, which is very hard to do. And that's why we have these numbers showing that we don't do well at this. A big way that we work is collaboratively. So that's the first thing. Most of the practices we work with, if we go in saying, hey, we want to do a research study, they get scared and we don't even get in the door. It's much more talking about the topic and what we want to work on because most everyday clinicians are so busy trying to survive every day. The idea of doing some big clinical trials, not what they're thinking about. We try to have a real world focus. We do community engagement and we do focus on primary care since that's where we're at. As I said, we try to do research that matters to primary care, making the right care at the right time easy to do. We used a lot of engagement approaches and we try to measure improvements for patients. We try to measure improvements for clinicians. And we try to do it at a statewide level. So I'll show you some of this. I think there's strengths that the PBRNs bring. So a lot of our clinicians and practices, they have questions and they actually want to be involved in generating new knowledge and feel like they're contributing and on a cutting edge level. It's just more about how to do it. So that's where the PBRN kind of brings in this expertise. So, we kind of view ourselves as spanning and convening across practices and health systems bringing practices in their leadership together, bringing practices in informaticists or policymakers or payers together. And a lot of time what we try to do is to give the clinicians and the communities that we're serving a voice. Like, what are they struggling with? What's working? What's not working? And how do we make them feel like they're heard? And that can be hard these days on a policy and payment and informatics level. So we try to do that. And then the other thing we do is we help them with data. So data is really important for research, but it's also really important for informing your care and quality improvement. So we try to break down these data silos, help people to get access to their data, kind of link different data sources. And I'll show you some of that with some of our studies, and have people start thinking about, well, how could we use this as part of our care delivery process and improvement? Here are some of our studies. And I'm going to mention, I'm going to go into some details on some of these. We'll talk about the Virginia Cancer Screening Research Network and the Vanguard trial in a second. There's another study we're doing. It's a PCORI study called the NOSES study. So believe it or not, there's never been a study to show how to treat a sinus infection. Right now we've got all this mythology like 10 days out or dual sickening, you give them an antibiotic. It's all made up. There's actually no data on that. So we got a PCORI grant and we're doing a comparative effectiveness trial where patients with dual sickening or at 10 days are randomized to antibiotics or nasal steroids or both or just saline. So, and we're right in the middle of enrolling for that trial, and we're doing that with 6 other universities. Another thing that we're doing is we're developing the opioid abatement, a toolkit for the Virginia Opioid Abatement Authority. The cities and counties in Virginia got all those opioid abatement funds from the Sackler case, and they're supposed to be spending that money to reduce deaths. And so we've been trying to help each city and county understand what are the factors in their area and how might that influence what they're spending money on. I'll show you a little bit of that data as well. And we have another trial called the SUSTAIN trial, where we're doing some practice facilitation and helping individual practices create some type of a quality improvement around addressing unhealthy drug use. And it can be smoking, alcohol, opioids, whatever you want. So like my residency, I'm up at the Fairfax Family Practice Residency. We're in this study and we're trying to use it to create a curriculum to teach our residents about Suboxone prescribing. So that's a study we're recruiting for. So if any practices want to do that, we'd help with that. And then the Virginia Mental Health Assistance Program, if you don't know about this, it's a training and a linkage program to help primary care do better with addressing mental health needs in their patients. And it's the Medical Society of Virginia is fielding it for the state, and we're doing an evaluation for them. I'm going to show you what we're doing around assessing primary care capacity in Virginia. And we're doing a study also looking at ownership. There's been a big change in primary care in Virginia. We went from 30% of practices in 2018 being owned by hospital systems to 60% in 2022 being owned by hospitals. And so we're looking at, well, what's the impact of ownership on quality of care, burnout, satisfaction, some other factors. And then we're looking at the state of interprofessional team-based care. And I'm going to talk a little bit about a population health study that we're doing to create a dashboard around health outcomes to try and address different, equity issues in different communities. So let me start with an example here of one of our studies, and there are practices here in this region who helped us with this study. This was a grant that we just finished off, and it was a practice facilitation study to help primary care practices screen and counsel patients for unhealthy alcohol use. So you probably heard a lot in the news, alcohol, there's some interesting things going on right now with it. But just overall, it's the 3rd leading cause of preventable deaths. It's the 8th leading cause of death overall. And 2/3 of deaths from alcohol are related to long-term consequences, and 1/3 are from the acute effects, things like accidents, suicide, and overdose. And unhealthy alcohol use is actually very expensive to our nation and to our healthcare systems. There's been discussion about, is there a safe level for drinking? So the World Health Organization recently said any amount of alcohol can cause cancer. And there's some data to show that. But there are also linkage levels that we say, well, this is an unhealthy level. So that's, generally more than 7 drinks per week for women and more than 14 per week for men under 65. And then there's alcohol use disorder, which is kind of more when you start having personal problems from alcohol. It's affecting your life, whether it's relationships or school or home, and that's based more on a DSM criteria. So the U.S. Preventive Services Task Force recommends that primary care clinicians routinely screen and counsel patients for unhealthy alcohol use. It's a B recommendation for people age 18 and above. But it's not done well in primary care. So, and we know it's not done well, and I'll show you some of this in a second. And the way you screen is with one of two instruments. It's either the audit C, where you ask people 3 questions, on average, how many days a week do you drink? When you drink, how many drinks do you have? And how often do you have 6 or more on an occasion? Or there's the SAS-Q, which is just asking that last question, kind of getting at binge drinking. So those are the 2 validated recommended instruments. Now I'll say primary care actually does ask patients a lot about alcohol, but they don't often use these instruments. So they're more often to see a patient in the visit and say, you don't drink too much, right? So, and I'll admit, I didn't systematically use these questions either until we did this study. But when the task force looked at the evidence on treatment for unhealthy alcohol use, what they found is that primary care can actually be very effective at helping people to stop doing unhealthy drinking levels of drinking. So, and it's not much harder than smoking cessation. So we think of it as being a very intensive type of a thing, but there were 65 different trials that the task force reviewed. Some of them only took most of them were only 1 or 2 sessions, and some of them only took 2 to 5 minutes. So they can be very brief, things like normative feedback and telling people what healthy limits are and what the guidelines say you should or you shouldn't do. And what the task force found is that those brief interventions resulted in reductions of the number of people drinking above the recommended weekly amount and binge drinking. And that has a reduction in leading to alcohol use disorder and complications from that. So it's pretty strong evidence here with this. So this was funded by the Agency for Healthcare Research and Quality, and they wanted us to recruit 125 practices to do practice facilitation, to go in and meet with them and have their teams kind of come up with a plan on how are we going to implement screening and counseling and treatment for unhealthy alcohol use and alcohol use disorder. And then what we did is we did a practice level randomized controlled trials. They were randomized to get this facilitation up front or 6 months later. And then we did a random check of 60 charts of patients that came in. And we saw, well, how often were they screened and how often were they counseled and what type of treatments did they get? We didn't get 125 practices in the end. I think we got 78. It's on one of my slides here, but we started recruiting in February of 2020. Very bad time to recruit practices to do a research study. So we were pretty proud that we got the actually 76 practices we did. And we created a whole toolkit, and they had these sessions to kind of think about what they'd want to do. And this toolkit's still publicly available. It's got the screening instruments. It's got all these different treatment programs in every community. It's got flyers and handouts, things you can give patients like diaries and other things. So as I said, we recruited 76 practices, and we started out going through residencies because, well, we're at a residency and we thought it'd be a nice, great way to get kind of people we've trained in our local communities. And that's our first wave. And the blue is the people those practices served in the community. And then we realized, though, we're going to have to do a little bit more. And we reached out to health systems, and Centera was involved. And then our third wave, we were like, oh, we're missing a lot of Southwest Virginia. So we reached out to primary care then. And then our fourth wave is just Hail Mary, who else can we get in the study? But the 76 practices and getting a little bit to the public health impact and the representativeness, when we looked at these 76 practices and the 60 patients per practice at 3 time periods, that's close to 12,000 patients we looked at, the people looked just like the distribution of Virginia. So very representative in terms of race, ethnicity, insurance, education, rurality. And we had patients that were from 98% of the census tracts throughout the state. So we got a lot of people with a very broad representation. So here's the first thing we found at our baseline in our practices. Well, we don't do very well in screening. So it was around 1 to 2% of patients were getting the SAS-Q or the audit C in terms of their screening instruments. And we weren't doing very well at counseling, and we weren't doing very well at referring and giving medicines. And medicines for unhealthy alcohol use are very effective. It's things like naltrexone or acamprosate or even gabapentin. One of the things we found from the study is that primary care is very scared to prescribe medicines for unhealthy alcohol use. And I don't understand that, because like gabapentin, primary care doctors give that out like candy. So I don't understand why we won't do it for alcohol. And naltrexone is really easy. It doesn't have many side effects or problems or anything. But that is still a problem that remains in primary care. So here was our main outcome. And just to put the population level impact about kind of where we can kind of move the needle on helping the health of our community and our state. So if you look at using the second area there, screening with the audit C or the SAS-Q, our intervention sites at baseline, 2% of their patients were screened, but at 6 months it was 35%. And and then that change was sustained over a 12-month time period. And our control sites didn't change at all, went from 0.4 to 1.4. I've not had a study where we've shown a 33% absolute increase. Relative, but 33% is a lot. Interestingly, they didn't identify many more cases of unhealthy alcohol use. And that's like putting it in the diagnostic codes. And that might be because clinicians are hesitant to do that. You know, that has stigma and implications for patients and other things. We talked about even just diagnosing if they have unhealthy alcohol. Maybe you just diagnose that you screen for alcohol use and that's your code. But we didn't really increase that. Although I think we increased detection of unhealthy alcohol use. And we increased counseling. So in our intervention sites, counseling increased from 26% of patients who had unhealthy alcohol use on their screen to 62%. And the control, they went up a little bit, 45 to 55, but it was once again an absolute difference of like 30+%. So putting this into perspective, we did a random sample of 60 patients of these practices at 3 time periods, but these practices collectively see 412,000 people. And what that means is that 33% increase means every single year now, moving forward, 114,000 Virginians get screened that wouldn't have been screened otherwise. And we'd identify 8,000 extra people with unhealthy alcohol use and give brief interventions to another 5,000 people. That's a pretty big population public health impact that working collaboratively across primary care can have. Our next steps is we got to do a better job on having people come back for follow-up visits and referring them out. Cognitive behavioral therapy works great, or getting them medicines. We were going to drive to every practice to do these meetings and these facilitations, but instead Zoom came out and there was COVID and we couldn't go there. So we did it virtually, and we calculated how many miles we saved that we didn't have to drive. And it was 32,000 miles. And I think that was equal to something like 160 acres of Amazon rainforest that we saved by not driving. So I was kind of happy by that. That was just a different angle to it. So I already mentioned sort of these future needs. We think it was a successful study, but there's a ton more work to do in Virginia in primary care around unhealthy alcohol use. And that's partly where that SUSTAIN trial's kicking in, but that can be for any substance. I want to talk next about some work we're doing with our Translational Science Center and this project that we call VA Ahead. And it's using a method that a population health method that we have been working on called bright spotting and community asset mapping. And it's trying to look at data a little bit differently. But we got a grant from NIH to create this dashboard that we're calling VA Ahead, the Virginia Accountable Health. I'm blanking on the name of it right now, but it's a health outcomes dashboard, a health engagement and action dashboard, and I can't remember the first name, and I created the acronym, so I'm sorry about that. But what we said is that there was this translational science need to co-create data systems with the communities to allow them to identify different health outcomes and the underlying causes for those outcomes and where they might be doing better and where they might be doing worse, to track these changes over time including impact of work that a health system or a clinical practice or a policy change or a research study might do, and then collaborate to develop priorities and solutions. And so we're trying to use data that we generate with communities to create a system of accountability to track things over time. And we're trying to take a strengths-based approach, and I'll explain that in a second, where we want to look at bright spots, like what are communities that are doing better than expected? Because it's always easy to go to communities and say, oh, you have terrible outcomes. Why do you have terrible outcomes? But how can we look at communities that are doing better than expected, understand why, and then get those resources, approaches to other communities? And then we wanted to look at the full range of socioecological things. So in healthcare, it's so easy to sit here and say, oh, people are dying from opioids, we need to prescribe more Suboxone. Well, that'll help some, but there's a lot of other things that are contributing to opioid misuse that have nothing to do with the healthcare system. So we wanted to look at all those factors. So this is what we think of when we talk about bright spotting. And I'll show you an example of opioids with this, but we identify a problem and we identify the socio-ecological factors that we think lead to a different outcome. So let's take opioid overdose deaths, and like, what are all the things that might lead to an overdose death? And then we try and get data for all of those socio-ecological values and that health outcome, and we create a model for the state and a multivariate analysis on a statewide level to kind of predict the outcome based on those socio-ecological variables. And then we go back and we use that model that we create, and we do the model for every single individual census tract or city or county. And we find the ones that are doing better than predicted. Actually, their outcomes are better than what the model would predict, and the ones that are doing worse than predicted. So if you're doing better, we call that a bright spot. If you're doing worse, we call that a challenge spot. And then remember, we also have hot and cold spots. A hot spot just means you have bad outcomes, and cold spot means you have good outcomes. But then we go and we look at these communities and we say, well, why are they doing different? And some of that is data, and some of that's community engagement and going into communities and talking with the people who are there to understand what's going on. And then we try to find these factors that are contributing to the different outcomes. The purpose of this study is to help researchers, clinical care teams, policymakers, and teachers use this data to do a better job. And we'll do well. Our outcomes are to show that people are going to use it, and it'll help to inform these different activities. And then we're going to recalculate everything year by year, each socio-ecological variable and each outcome. So this is the hot and cold spot and bright and challenge spot. But let me put a little more, I'll get a little more concrete here in a second with opioids. We put all the data in this map called Health Landscape Virginia. It's kind of wonky. It's a GIS tool, but you can download any of the data that's there. And if anyone wants to do anything and they want any specific data, we can generate data for them. And we get all of these variables from a bunch of different resources. So like we have the state's mortality data. So for opioids, we know every person who died, by the census tract that they live in. So we're able to calculate these census tract and city and county level measures of outcomes like death. And we use the state's all-payer claims database. So that has about 60% of all Virginia residents, 100% of Medicaid, 100% of Medicare. And we can use this to measure other things like, are they being prescribed Suboxone? Did they get a mental health visit? Did they see a primary care clinician? Did they have an emergency room visit or hospitalization? So we can look at all these different things. And then there's a bunch of public data as well, things like the census tract and Bursavis and CDC and other data sources. So we pull all this together to create these city and county level measures. And then we try to use that for these bright spots and other things. So this is the dashboard we'll do. So we're going to think of the health landscapes like the researcher, wonky data person site where you can download things. But the VA Ahead dashboard, the purpose of this is going to be more for our community members and other things. So it's going to show the data a little bit more in a refined, clear, understandable way and link people to tools and resources and try and actually bring people together who are trying to address these different topics. We're supposed to address 15 equity topics, and we've been pulling them together with our community partners. The black ones we've started. So we're looking at opioid overdose, primary care access, mental health, colorectal cancer, cultural arts, adverse childhood events, and obesity. Some other topics, the gray ones, were ones community members said they wanted us to address, and we'll be doing those later. So for example, I'll give you something that we're still working on right now with adverse childhood events. In our modeling, one of the biggest things that we found that is a modifiable factor linked to increase or reduction in adverse childhood events, i.e. children being hospitalized or going to the emergency room with child abuse. It's increased percent of people with Medicaid in communities reduced adverse childhood events. And at the same time that happened, we saw reductions in uninsured also reduced adverse childhood event. And we can see this from 2016 to 2018, you had one rate of adverse childhood events. It went down after 2018 when we did Medicaid expansion, and we went from 16% uninsured to 8% uninsured, and the Medicaid rate went up. So, and it's very clear in our data. And so you can imagine what's going to happen with the new HR1 bill in reductions in Medicaid and increase in uninsured. We'll see adverse childhood event rates go back up. If our data is causal, it might be associative. Let me show you a little bit about opioids. So this is our bright and challenge spots for opioids. So these are the communities, the blue ones are the communities that had less deaths than predicted. And we put a bunch of things into this model, everything from disability to healthcare access to poverty to inequities, this Gini coefficient, to Suboxone prescribing, mental health visits, and other things. I'll show you some of the ones that came out to be significant. The size of these dots is not the area, it's how big of an effect there was. You'll notice in your area, there's a lot of blue dots. You have a lot of communities around here that are bright spots, and they're doing better than they should be. But we also see these challenge spots. These were the modifiable differences. So prescribing more medications like Suboxone had a positive impact. Access to primary care, positive impact. Population density, now being in a rural area is better. Used to be rural had higher rates of death, but right now it's the urban areas where the deaths go up. And then we found this local collaborative and collaboration and innovation, and that was right near here. And then there's other factors that we don't understand. But here's all the red down there, that's all the challenge spots, and the blue are the bright spots. And this is a graph where on one side you have the number of primary care visits, and the other axis you have the number of MOUD prescriptions. And you can see there's a strong correlation. If you have more MOUD, if you have low numbers of primary care visits, low numbers of MOUD prescribing, you're a challenge spot. So, and pretty clearly, those other two areas are independently effective. And here's some other things, like this is just the bright spot versus the challenge spot, and PCP visits, mental health diagnoses. Communities that did better had more mental health diagnoses. That doesn't make sense at face value, but when you go and you talk and you work with different communities, what you start to learn is this is about delivery of care. So probably the bright spots that have the higher number of mental health diagnoses is more like the right rate of diagnosis. And the challenge spots represent the difference is all the people who are not getting care who should be getting care. They're not going to a healthcare provider. They're not being treated and diagnosed for their depression. So it probably represents a lot of undiagnosed disease. So as part of our opioid abatement assistance, we've been helping a lot of different communities. So we work with Petersburg, and we're working with Chesterfield and some other 4 or 5 other cities. And the Petersburg area was very interested in maternal deaths from opioid overdose. And so when we looked at a lot of our data, and then we started working with the different care providers in their community, we found a big issue there was recovery housing. So communities did better around maternal deaths if they had more recovery housing. So this is, if you're pregnant and you're diagnosed with opioid use disorder, it's a place you can go live and get treatment and get support and not be homeless or not be in an unsafe environment. So they're actually using the Opioid Abatement Authority funds to create more recovery housing in their communities to make a difference. So we kind of hopefully are going to chalk that up as a win, that they're doing the right policy to make the changes that we want them to do. Now in your area, what we found, Appomattox and Northampton, they created this overdose fatality review team that's been meeting for about 10 years now. And anytime a member of their community dies from an overdose, they bring together all the people who might make a difference. So this is everything from primary care to addiction specialists, mental health, law enforcement, school, social work, emergency rooms, police, all these different groups come together and they review every single case and they say, how do we fail this person and what do we need to do next time? And it ended up resulting a whole bunch of bright spot communities that are doing a lot better than you would expect. So we're rolling this out with all these other topics. Colon cancer is another example. We find with colon cancer, you have higher rates of death in rural communities is a big factor. But interestingly, there's higher rates of screening in rural communities. So we're trying to understand what's going on there. And there isn't much of a delay in the time from diagnosis to treatment, which was another factor we thought might be there. But that's something we're looking into more. So we're trying to roll this out and create this scorecard and try to make sure that people are able to use this data for research and clinical care and teaching, and our policymakers might use it to do some good things. All right, completely changing directions. So we've had like a practice level, practice improvement trial. We talked about a population health community engagement type of an effort. We're going to talk more about a pure clinical trial. So Virginia's created one of these cancer screening research networks. And this is a partnership between VCU and Centera and Inova and our ACORN practice-based research network. There's 10 of these funded across the country, all of these places. You got big places, big name places like Henry Ford and Kaiser and DOD and VA. And then you got Virginia, VCU and Inova and Centera there. And I'm pretty excited about our hub compared to others because I think we're a little more primary care focused. A lot of the other hubs are more grounded in their cancer centers and other types of places. And we're doing very well in this. The Cancer Screening Research Network, NCI, is trying to create this group across the country that could then field trials to screen, to test new cancer screening technologies. And they're testing this out with the very first one, and they're calling this the Vanguard trial, where we're supposed to be testing the new multi-cancer blood detection tests. You guys heard about these MCED tests or multi-cancer blood detection tests? I see some no, some yes. So MCED tests measure changes in your DNA or protein in the blood that suggest that you might have cancer. It doesn't make a diagnosis of cancer, but it detects these DNA and RNA changes that are markers that you have cancer in your body. And it can give you a tissue of origin. So it might say something like you might have liver cancer or you might have colon cancer. But then you actually have to go and do the diagnostic workup. And these MCEDs have been tested in the UK in a big trial called the GRAIL trial. And the results are supposed to be coming out in the nearish future on that. They don't have a control group in that trial, if I understand it correctly. So it's a little bit different design. And this Vanguard trial, we are randomizing people to either get the Guardian MCED test, which can find all of these different cancers, or they're randomized to the SHIELD test, which can find those cancers, or they're randomized to continue usual cancer screening. And this is not meant to replace usual cancer screening, it's done in addition. So we're trying to encourage everyone to get their usual cancer screening. So we just started this trial in June, and the purpose of it is actually, it's more of a feasibility trial. Like, we want the answer. Does this reduce death from cancers? That's the outcome we need to show. There's already data on sensitivity, specificity, and positive and negative predictive value, but we got to know, is it going to find the cancers that we can do something about at a phase that we wouldn't have found them otherwise? And is it going to change it? Is it going to prevent someone from dying from cancer? So, but the feasibility trial is to set up this large trial. So I mentioned that there are 10 hubs. These 10 hubs are going to recruit 22,000 people collectively, each of us about 2,000 people. And then that data is going to be really used to design the big trial, which I imagine is going to have 100,000 to 200,000 people in it. But they'll use the power calculations from this and everything. So what we're doing is our patients get the MCED test and complete a survey about all their cancer screening at 1 year. They do it again at year 2, and then at year 3, they just answer about cancer screening and cancer history questions. We're trying to look at, are we able to recruit a population that's really representative of Virginia? And how do we recruit people? And can we retain them in the study? And then what are the different outcomes we see? So we have a clinician-based and practice-based recruitment strategy. We recruit a targeted strategy from lists of people that we have who've worked on other studies with us and maybe want to be in this study. We do community outreach, and then we have some virtual outreach. We do have to be a little careful. So John Sales is one of the investigators here. He did a TV interview in this area, and then Pat Nana-Sinkum and I did too in Richmond area, because the media heard we were doing this study and they wanted to know about it. And in 3 weeks, we had 2,750 people call us, and we can only enroll 2,000. And those people were not really representative of the broad group that we'd like to include in our study. So we're trying to be a little cautious. As of August 24th, we had 138. I think we're up to 270 now. And we've been mainly limited by the number of test kits we could get. And we've not done as well in the representativeness as we'd like, if you look up there in terms of race and ethnicity. But we also don't have our consent materials in Spanish yet. We're waiting on those, so that might help with that. And we're going to try to recruit a little bit more in the upper age group, the 65 to 75. We were trying to balance across all 3 age groups. It's 45 to 75 without cancer. So a lot of people can be in the study, so it's very broad and inclusive. I'm going to talk next about primary care access. So that's an example of a pure clinical trial. And earlier, when I mentioned our sinus infection trial, that's another pure clinical trial. Like, you're randomized to one of 4 arms, and we're following you with these different outcomes, and we're measuring a C-reactive protein. And at one point, we were even doing nasal swabs to measure the viruses people had. But so those are pure clinical trials. So here's another one looking at statewide level about access to primary care. So in the Implementing High Quality Primary Care report from the National Academy of Medicine in 2021, the report said that primary care is the one part of our healthcare system with data that shows it extends the life of communities and reduces inequities in communities. So primary care is really important, and we should think of it as a common good, something that everyone should have access to. But at the same time, we also know that primary care in the US is under some stress right now. And there aren't enough primary care clinicians, and there aren't enough primary care practices. So we're trying, and we've been working with the state since 2017 to understand access to primary care. It was part of the state's efforts with Medicaid expansion. Okay, if we expand Medicaid, will people be able to get care? So we've been identifying every primary care clinician and every primary care practice in the state. It sounds easy to say, well, who's primary care? But it's really hard to say who's primary care. So if you look at like the state licensure data, the discipline that clinicians list don't track very well with what they actually do. And there's tons of people in that list that aren't practicing anymore. And if you look at another file like the Medicare, there's a Medicare file on clinicians that's notoriously incorrect in terms of identifying primary care. So we've been linking a bunch of different data sources, the National Provider Plan and Provider Enumeration System, or NPAS, the state's all-payer claims data, and our state licensure data. And then we're manually checking on who's practicing primary care, and then we nest everyone into practices, and we're trying to follow them over time and say, do we have enough primary care? So we don't. Here's the short answer. Virginia's short on primary care, and the green areas are where we have enough primary care, and they're pretty much centered around where our residency training sites are. There's even a couple rural residency training sites. And you can see, up here, let's see if I can use this. we don't really need to do it. But in the upper northwest, that's like rural Shenandoah. That's where one of our residents, where a residency program is, and they should actually not have enough primary care, but they do. And in that southeast central, it's pretty empty right now, but a residency just opened up there. So it'll be interesting to see if that closes up. It is very much a rural-urban distribution, though, too. So a lot of our rural communities don't have enough primary care compared to urban. One thing that's not on here that I didn't say that's really interesting is if you start looking at access to communities based on their community characteristics, and you start thinking of communities that are historically more disadvantaged, more uninsured, more Medicaid, more poverty, higher proportions of Black people, if you're in an urban or suburban area, you actually, and you're in a more disadvantaged community, you actually have better access to primary care. Doesn't mean you use them, but there are more primary care clinicians in underserved urban and suburban rural communities, urban and suburban communities. It's the exact opposite for rural. So in rural communities, if you're more disadvantaged by those characteristics, you have less access to primary care. So I think this is a benefit of our FQHCs and some of our loan repayment programs and other things. We need about 24% more PCPs today. That's about 1,200 primary care clinicians. We have 4,872 in Virginia right now, nested into 1,962 primary care practices. And disturbingly, 30% of our primary care clinicians are over the age of 60. So only 20% are under the age of 40. So that disparity is likely going to get worse and not better. Now, VCU, and if you want to do this for you all, I'm happy to do it for you. We've got lists of all of our graduates, and we know where they're practicing. And we've looked at, like, what do our residency programs do for closing the gap of care in Virginia? And we've been able to show that our VCU graduates take care of about 15% of everyone in Virginia. So they care for about 1.3 million Virginians, and we can map out where the graduates are and who they're caring for and be able to show the impact of our training programs on the health of Virginia. And we've used that when we talk with the legislature to try and make sure they keep funding our residencies, because I think that's important. We've also been measuring different characteristics of primary care. So you've probably heard of the 4 C's. So like access to care, continuity, comprehensiveness, and coordination of care. That's what primary care is supposed to be doing. And we've been starting to measure that for each clinician and for each practice. And this is panel size, how many patients you see, and continuity. And what you see is that clinicians who have really big panel size have pretty low continuity. So they're not seeing the same people over and over again as much. And that probably represents a lot of urgent cares and patient firsts, which we technically do call primary care in our lists. So that 30% more primary care includes all of our urgent cares doing primary care right now. And the average panel size has shrunk over time. So right now, the average panel size for primary care in Virginia is 1,280 some patients. That's what the average primary care clinician sees in a year in terms of unique people. We've also seen comprehensiveness go down. So there's a measure, and you can argue it's not the best measure because it counts things like do you do OB and circumcisions and all the sports medicine and other things too, which maybe that's not exactly primary care now, but there are different measures out there. But we've seen it go down over time. And there's a really interesting bimodal peak. I think that that peak on the further outside down there, that's probably your real longitudinal primary care. And your peak closer to the other peak on the earlier end might be more your urgent cares. And our rural clinicians have higher continuity and higher comprehensiveness in Virginia. And there's bright spot communities that are doing better with the comprehensiveness and actually increasing, not decreasing. And your area is in the increasing area. So more clinicians in this region are doing better at comprehensiveness. My area is doing worse. So we got the blue dots there, and we're doing worse up there in Northern Virginia, which isn't too surprising. But we're hoping that we actually can create kind of a scorecard that we can give to every single practice and every single clinician so that they can see how they're doing with comprehensiveness, continuity, length of relationships, and coordination of care. And we're hoping that we can give that to everyone in Virginia to try and help them inform their care delivery models and make improvements to better care for their patients. So I'm going to end here. We covered a bunch of different studies that cover a span of everything, and I think there's even 10 minutes for questions. But going back to this model of the ecology of care, ensuring that research benefits everyone, it's hard to do this. It's like there's a reason why research is primarily in the academic centers and applies to 0.1% of people. If you look around this campus, it's a lot easier to do a study like right here where you have everything than to go out and do it in the community or to do it in a practice. But if we really want to improve community outcomes, getting this out into the communities that we're serving is really important. And we love having anyone participate in ACORN in any way they want. And we actually think that there's some real opportunities with moving beyond traditional research. I like the clinical trials like the Vanguard and our noses study, but even thinking differently about some of the population health data and linking that with quality improvement and how we're delivering care to different people, I think that can have a big impact on closing those gaps I showed you at the beginning, where Americans are only getting half of what we know they should get. So that's what I have for right now.
Wonderful, wonderful talk. Thank you, Dr. Krist. Questions for Dr. Krist? So you see, you have these silver boxes in front of you. There's a red circle. Press and hold it as you are asking question, so that your question can be heard by people who are joining us virtually. Go ahead, please.
Thank you. It's a fabulous presentation. I have two questions. One is, you've beautifully shown the movement away in American medicine from the medical model to a public health model. For example, I've been very involved with the public health view of dementia statewide here, and you've done some fabulous stuff. So my question to you, number one, is what do we need to do in the education of our learners to bring in these public health views? That's question one.
Yeah, I think that's a great question. I like this audio system. That's very cool. Very cool. I think having folks kind of be aware of like I'm hoping with that health equity dashboard as an example, and being able to see, like, if you think of clinicians and even learners in a setting and starting to take a little time and think about, okay, well, from a practice standpoint, what's my 70% service area? Like what's the region that I take care of where most of my patients are? And some of the things we're trying to help people think about is, well, who's not getting care? Like, what's the needs of your community? Who's not getting care? We're so focused on who's getting care. I can run my queries on my patients and who's up to date, who's not, what's my quality measure, and it just tells me what I'm doing for the people I'm seeing. So getting people to think a little bit different about the population that they're seeing, in addition to the person they're seeing in person. The other thing I think about is the other big thing about public health, it's about systems of care, right? Like a big part of our improving around the unhealthy alcohol use was getting practices to think about, well, what is our system of care? What's our routine approach? How do we reach out? What do we do? And I think you can apply that to lots of different aspects of care. Like cancer screening doesn't have to occur just during a visit. Can you do a system-wide practice level, community level intervention? So I think those are all great things.
Thanks. The second question is, you mentioned the National Cancer Institute and funding coming from it, but as you well know, it's been slammed big time. Preventative Task Force that you used to serve has been slammed big time. What's your response to these changes that are occurring right in front of us right now?
Well, the other hat that I wear is I spend a lot of time trying to talk with policymakers. So I've been meeting, at least personally, with all the staffers on the Senate and House health committees, trying to advocate for the U.S. Preventive Services Task Force. I think primary care needs to think of USPSTF as a really important resource for us. And what's important about it is not who's on it. It's not necessarily their name per se, but they have a structure, an approach, and a process. And that structure, approach, and a process, it's grounded in evidence, it's objective, it's not politically influenced. They have scientific independence, and the different members are appointed by the scientific community, not for any other reason. So at least for me, getting those messages out is very important. There are some good news. So you're right, these organizations have been slammed. So ARC, which I mentioned a couple times, and they funded most of my work over my career, they've lost 70% of their staff. So they've all been RIF'd or early retirement. So ARC hasn't gone away, but 70% of their staff has. I'm hoping they can rebuild. There's a lawsuit right now from Knapp-Craig and Academy Health suing ARC to maintain research, because they're the only funding agency with legislative authority to fund primary care. So they're really important to protect. The Vanguard trial's not actually lost any funding. So Congress loves studies on detecting and finding cancer. So they haven't threatened that yet. And actually all my other grants usually get a 10% cut every year. Our Vanguard trial, we got a 10% cut, but then it got re-awarded back to us. So they're still investing in that. And if you look at the budgets, the Senate budget still keeps all the NIH funding. And CDC and ARC and HRSA, they kept the task force. They reduced them from 11 million a year to 7 million a year. The House budgets and the presidential budgets are not as kind to NIH and those other funding agencies. But I think talking to our legislatures, making sure that they know that this is important. We actually need data and science to inform and direct what we're doing. I think getting those messages out is important. And I think even making sure our patients know this type of stuff is important. Like the members of ACIP, we have to trust that they're going to make recommendations based on what's going to help our patients and not have any other type of a motive in whatever recommendation they're going to make.
Other questions? Go ahead, Talal.
Thank you for the beautiful presentation. My question is related to the role of other healthcare providers. So especially thinking about now the management of diabetes, obesity, there's not enough endocrinologists or obesity specialists. What is your experience in including other providers, thinking about pharmacists or dietitians, for instance? Is there evidence to show that that might benefit primary care practices, or maybe there's not enough evidence yet? Thank you.
Oh, it's a great question. And, you know, I'm sorry I didn't talk enough about kind of other specialties and other providers. You know, the other part of the implementing high quality primary care is they actually changed the definition of primary care. Primary care wasn't a clinician. It was interprofessional teams caring for people, providing primary care services. So, you know, you mentioned things like pharmacists, you know, there's behavioral health, social work, all these elements are critical parts of primary care. Actually, high functioning primary care needs to have all of those supports and services, and including specialty care, endocrinology and others. So we've actually done a number of studies that are about collaborative care models. We've done ones on nurses working at the top of their license. We've done ones about, you know, working closer with primary care and mental health. We've done some diabetes studies with primary care and diabetes or endocrinologists. And I didn't mention, even with the unhealthy alcohol use, we were creating partnerships between the primary care clinicians and the addiction medicine doctors as well. So, you know, I think any part of our healthcare system, it is about collaborative care. It's the interprofessional team. And that's one of the 4 C's is coordination of care. And that is across different specialties and providers for the patient, and kind of managing that so that it's a systematic, coordinated, whole person type care for a person. Yeah, so that's a great question.
You have
So, Alex, thanks so much. Great talk, and it's great to see you. I really applaud all your work, and it's a pleasure working with you on the Vanguard study. It seems like hypertension would be an ideal diagnosis for your approach. We're doing a PCORI sponsored study where we're testing the effectiveness of remote blood pressure monitoring, and we've
develop the IT connections between a Bluetooth-enabled blood pressure cuff to go to a hub that sends it to directly into our electronic health record. And it seems like that type of systems approach would be an ideal model. And maybe, we're just about through with the recruiting phase of this study, and 6 months later, hopefully we'll have results. And if it's positive, it would be interesting to do an implementation study. How easy would it be to implement that type of technological enhancement to primary care, across the state, if it proves to be beneficial?
Yeah, I think that's exactly true. I remember in 2018, the task force updated their hypertension recommendation, and it's just about screening. And I remember we kind of scratched our heads and we're like, really, you want us to relook at the evidence on screening for hypertension? I mean, we know it works, but the big change and the thing that we said that was different, but it's not different, is to not trust just the reading in the office. So we were very clear, that was the big thing, that there's a lot of evidence that patient collected, remote monitoring, 24-hour blood pressure monitoring, all of that's important and better than just that office reading, and combining it all is important. And I think for any primary care clinician, one of the challenges we have is information overload from our patients, from just what's in front of us with the EMR, but now also with remote monitoring. So I think being able to think about, well, how do you do remote monitoring and get that right information to the clinician at the right time so that it influences care? I think there's a lot of promise with that. And Medicare, we were talking about this over lunch, they're implementing a new payment model with primary care called Advanced Primary Care Management to give a per member per month payment for all the work you do outside of a fee-for-service encounter. That's the type of work they're talking about. It is actually coordinating care in different settings. And I know my patients, I have like a 5-month waiting list to see my patients. They can't come in and see me. And so I do a lot of kind of asynchronous care through my chart and other things. And doing this with something like having some data to help inform that, I think a lot of clinicians would like that, as long as it doesn't make their lives miserable. So too much would be bad.
It sort of leans itself to team-based care too. We have a nurse practitioner who helps
Exactly
with the inflow of pressures coming in.
Yeah, and it can be something that pharmacists and others do as well. I don't like, this is a personal thing, is carving out primary services. Like, oh, we'll have the pharmacist just manage hypertension. To me, it's still, how do you make it part of primary care, and how do you make it part of whole person care and a whole person approach? And the pharmacist has a big role, the data has a big role, and everyone on the team has a big role for that. Mm-hmm.
Thank you very much.
Yeah.
Thank you, everyone.